call this meeting to order, and our first witness this afternoon is Mr. Bruce Farr, Acting Vice President Operations for Orange. Mr. Farr, if you come forward, please. And hi. Good afternoon, and just to confirm that you received the letter for a witness coming before the committee.
Yes, I did.
Okay, very well, and I understand you want to swear an oath, so we'll have our clerk do that.
So the Bible's in front of you there, Mr. Farr. Do you solemnly swear that the evidence you shall give to this committee touching this subject to the present inquiry shall be the truth, the whole truth, and nothing but the truth, so help you God?
I do.
Thank you.
And did you want to make an opening statement to begin?
Yes, yes, I do, sir.
Very good. You go ahead with your...
Well, thank you very much. Good afternoon. My name is Bruce Farr, and I am the Interim Vice President of Operations for Orange. I very much appreciate the opportunity to speak to this committee today. It just so happens to be exactly 1 year ago today that I began working at Orange on a contract basis as a special advisor to operations. Considerable progress has been made over the past year at Orange, and I'm happy to be able to provide updates to you here today. I want to begin by telling you a little bit about my background and how I arrived at Orange last April. I began my municipal career in 1972 here in Toronto as a frontline paramedic, which was then known as an ambulance attendant. I spent a total of 39 years with Toronto Emergency Medical Services, 25 of which was spent in leadership roles within the fields of paramedicine and emergency medical dispatch. Among some of the accomplishments I'm most proud of, I was directly involved in creating the first advanced care paramedic position here in Toronto, as well as the establishment of the critical care land transport program. In 2003, I became chief of the Toronto EMS system, a position that I held for 8 years. I have also served as the past president of the Paramedic Chiefs of Canada, and I am still currently an active board member as their past president. I retired from Toronto EMS in February of 2011. As it turns out, though, retirement didn't last long. Not after I left the service. Orange's former interim CEO, Mr. Ron McCurley, phoned me and asked me to come in for a meeting with him. Having read much of the news around the service over the previous months, I really thought that I could be helpful in assisting the organization turn the corner. I was asked to join the team at Orange as a special advisor to operations, and that's a role that I held until I became the interim vice president of operations several months later. From my first days at Orange, I was really struck by the dedication of all the staff. We have high-quality people who come to work each and every day and do their very best under what I think you would all agree have to be very difficult circumstances. I was also struck by the complexity of the organization and how much opportunity there was there for improvement. I have seen the development of the air ambulance program in Ontario since its infancy in the late 1970s. At one point, the air ambulance even had its headquarters in the same building as Toronto EMS. From up close, we watched the growth of the program from a single base to multiple bases, right across Ontario. Dating back to the very beginning, I believe the plan was to have air ambulance fully integrated into the pre-hospital and hospital system. I think it's safe to say that somewhere along the line, that plan went way off track. Ontario has one of the finest systems in the world when it comes to EMS and pre-hospital care. My goal is to have Orange fit efficiently and effectively right into that system. It has never been more important than now to develop a big picture vision for the future of Orange, but we have not lost sight of the fact that important shorter-term goals need to be challenged within our day-to-day operations to ensure that we're providing the best possible service to the people of Ontario. Much has happened over the past year to make these necessary improvements, and I'm pleased to provide you with a brief update. One of the most significant areas of concentration has been our Operations Control Center, or the OCC. This is the nerve center of our operation. A single patient requiring transport can involve dozens of phone calls among all the different agencies, such as the Central Ambulance Control Centers, the sending hospital, Criticall, Orange pilots, paramedics, and physicians, and of course the receiving hospital. All of these calls funnel through our Operations Control Center. As you would imagine, it's vitally important that this process unfolds in a fashion that is as seamless as possible. Based on our analysis and the feedback of our crews in the field, as well as healthcare stakeholders, it became clear that there was much more room for improvement. So among the recent changes, we have replaced the old cross-training model for our communications officers with a specialized training model. We have introduced certification exams for those communications officers, and we require them to achieve a specific standard. And we brought together our medical call taking, our flight planning, and our flight following functions into the same control center. So that's the human side of the OCC. But for a control center to function well, you also need to give your people the right information technology tools to get the job done. The implementation of our computer-aided dispatch system, or CAD, has been a top priority in order to more effectively dispatch our crews and improve our ability to gather data and information. I'm very pleased to report that we have completed an open and transparent request for proposals process, and a vendor has been selected, and we will begin the process of implementing this software very soon. I should stress that the implementation will not happen overnight. We want to ensure that it is working effectively and that our crews are thoroughly trained before we put the system into active operational use. We've also made progress in terms of the utilization of our vehicles, our fixed-wing aircraft, which are best for long-distance transport, particularly in Northern Ontario, helicopters, which are best for on-scene response and inter-facility transfers, and our land vehicles, which are primarily used in our critical care land ambulance, or CCLA program, whereby patients receive critical care transport between facilities which are located relatively a short geographic distance from one another. We've also had land vehicles located at our air bases which can be put into service when weather leads itself into unsafe flying conditions. And we're mindful of the ongoing critical care land ambulance review by Deloitte, and we're providing them with any information that they require. Recently, we have implemented some pilot projects to make better use of those land resources. A critical care land ambulance utilization protocol has been established to decrease the dependency on land paramedic services in specific locations across the province. Thunder Bay, as an example, is the trial site for the use of a medical transport service to transport our lower priority patients between the airport and the hospital. This program has reduced the dependence on the local EMS service, Superior North, and has also reduced detention times for aircraft by 41% during this study period. In addition, we've launched another pilot project in Ottawa where we will use specific land vehicles rather than helicopters on certain kinds of calls. This pilot has already had very successful results. Recent data has shown an increase of approximately 20% of the use of land ambulances. This has resulted in a decrease, of course, in the number of rotor hours, which leaves the helicopter available to respond to higher acuity calls. Another project we're very excited about is something we call our readiness project. Optimal readiness in all phases of our operation results in the best outcome for the patients that we serve. And in practical terms, readiness means that when a shift starts, our paramedics and our pilots are standing by with their uniforms and safety boots on beside a fully equipped aircraft that is ready to go immediately when the call comes in. Being ready to respond is what the people of Ontario are expecting of us, and that's the inspiration behind this complex, comprehensive project. Our overall goals are to improve resource availability, on-shift resource readiness, and the overall operations efficiency of Orange bases by adding up staff time at no additional cost. So that's the big picture. But of course, putting those goals into action will require putting together all aspects of the operation. So we are just beginning this process. Right now, we're looking at a number of specific solutions, such as the introduction of a new computerized dashboard, which will show crew and aircraft readiness to the Operations Control Center staff. And it will be changed as their status changes. We're looking at enhancing the efficiency of our weather reporting by improving communication between our flight planners and our pilots. So in summary, we're looking at multiple areas of our operation, including a shift change protocol, aircraft readiness, dispatch protocol, as well as equipment on shift and workforce readiness. So what I've shared with you here today only scratches the surface, and I'm incredibly proud of the work that has been done to improve Orange's operations, and there's much more yet to be done. Rest assured that everyone at Orange is committed to seeing this through, and I have little doubt that Ontario's air ambulance program is well on its way to becoming something for the province to take pride in the future. Thank you very much.
Thank you very much, and we'll now go to the three parties for questioning. You have 20 minutes each, so starting with Mr. Klees.
Thank you, Mr. Chair. Welcome, Mr. Farr.
Thank you, sir.
Just want to say that the tour that we had at the headquarters was most informative and eye-opening in some ways, and I think encouraging, certainly in others, in terms of some of the progress that's being made there.
Thank you.
I just want to confirm that you were invited, as you say, by Mr. McCurley to come on as a special advisor. Was it in May of 2012, I believe, right?
It was in April, early April of 2012, where I received the call, and I actually started April 17th.
Okay. Do you know if there was a job search for that role?
I have no idea, sir. I received a phone call from Mr. McCurley and asked if I would come in to meet with him, which I did so about 4 or 5 days later.
Okay, so I'm assuming then that you and Mr. McCurley had a relationship of some sort. You knew each other prior to that?
No, sir. I'd never met him.
Okay. And why did he make the approach to you then, to your knowledge?
I can only speculate, sir. I don't know. I've never asked Mr. McCurley, but I assume that people that were around him had known of my status, certainly as the chief at Toronto. It's a Toronto EMS being a world-class and well-known high-performance EMS service, and the fact that I was retired. And I think, you know, in his words to me, he needed someone who could help him reintegrate Orange into the province's very fine EMS system, and would I come and help him? And sort of that was the kind of discussion we had.
So was there anyone else at Orange that you knew before you went there on a personal level or professionally?
Well, of course, in my role as chief at Toronto, we operated a critical care land ambulance component for Orange, funded by Orange, originally funded directly by the province. So I had interaction with a number of staff at Orange over the years in terms of maintaining administrative processes, control of budget back to the city, staffing issues, equipment issues, and so on. Frequently, not directly. One of my deputy chiefs would handle it directly. But of course, I knew people at Orange. Some of the people that were there in leadership roles were in fact colleagues of mine and worked at Toronto as paramedics before they chose to go to the air ambulance service a number of years ago, and they're no longer at Orange.
Okay. Who among the executive group did you know there?
I knew Dr. Mazza, I knew Tom Lapine, and I knew Steve Farquhar.
Okay.
Both Tom and Steve were paramedics at Toronto EMS previously.
I would think it's reasonable to assume that either Lapine or Farquhar would have probably referred you to Mr. McCurley.
I can't say, sir. I don't know.
On June the 11th, I put a question to the Minister of Health. And as you know, one of the serious concerns about Orange, apart from the money that was going missing, was the implication to patients and not being able to respond appropriately. And we had heard here about single staffing of medics and then patients having to be refused. I put a question to the minister that day about the fact that the new performance agreement did not have any specific standards of service identified in it. And her response was essentially that all was okay. I want to ask you this question. We have a new performance agreement. On review of that new performance agreement, there is nothing in that new performance agreement that specifically sets out standards of service. And by standards of service, I want to make sure we're on the same page. We're talking about such things as staffing, qualifications of paramedics, and what we in this committee understand are some very rigorous prescribed standards of service that mean that there have to be 2 paramedics, that those paramedics have to have a certain level of qualification. None of that is incorporated into the new performance agreement. The minister seemed to be of the opinion that that didn't really matter. Someone who has the responsibility of overseeing the delivery of service, and someone with your experience and knowing what happens when those standards aren't met, and the implication to patients, do you feel it would be helpful to have those standards of service incorporated into the new performance agreement?
Well, let me speak to a couple of issues that you've raised. I think first of all, that we are performing to standards that have been laid out for us. While I don't know the performance agreement off by heart, I certainly know components of it. We are expected to staff the aircraft as per our deployment plan across the province. And as you know, we haven't been meeting that obligation to staff it at the critical care level, although we've staffed it at either the advanced care or the primary care level in terms of paramedic certification. In terms of standards to respond to a call, we watch those standards very carefully. The time it takes to have our pilots do a weather check, the time it takes for us to, if the equipment is not outside, to get the helicopter, let's say, out of its base and outside, to ensure that it was previously stocked and ready to go into flight right away. They're all things that we track as diligently as we can, because that really speaks to the performance.
I'll rephrase the question. We have had representation that the previous performance agreement provides guidance, and that there were certain expectations in terms of what those service standards would be, and that it would be up to the individuals who had responsibility for oversight and enforcement to ensure that they were met. That didn't happen, which is why we ended up in the mess that we ended up in. Now we have a new performance agreement. We had an opportunity to actually incorporate defined levels of service in that agreement. We still don't have them. You come to this position of yours with good intentions. You have a background in EMS. You may well be conscientious at what you do and say, well, we're going to adhere to these standards of service. But once again, it's not in the performance agreement. And just from, and by the way, some of our research indicated that you were in the vortex of an issue at the Toronto EMS. An individual died. There was a report from the Ministry of Health. It made 13 recommendations in terms of training, in terms of other issues that should have been able to prevent that death. We're now at the point where we're trying to put in place improvements to this system and provide as much guidance as possible to avoid possible errors. And my question to that end is very simple. In your opinion, would it or would it not be helpful if in the performance agreement under which Orange must now work, if there were specific defined service levels that you could work towards, that the Ministry of Health could perform its inspection functions against and do its audits against, and that the world knows what those defined service levels are? Would that not make it easier, and would that not make it more efficient and more responsive?
Well, of course, it makes it easier and more easily understood for everyone involved, but I believe that most of it is in place. I mean, I don't need people to tell us in an emergency situation where someone's life is on the line, what we need to do to make sure we're ready to deploy a helicopter or a land vehicle, or paramedics to assist that person. We know what must be done.
And so did the people who were there before. That's my point. They would have told us exactly the same thing with all respect. What we heard time and time again, and even the minister kept saying, well, we didn't have the authority, we didn't have the instruction, we didn't have the details. And there are two sides to this. One is the ability of people to perform conscientiously. You may not need anyone to tell you, but maybe the next guy does. And if we have clearly articulated documents that make it clear what those standards are, then I think it's a lot easier for the Auditor General, for an Ombudsman, for a Ministry of Health inspector to have those meetings and say, by the way, here's where the failures are. And I think what I'm hearing you say is that you agree with me. However, in your circumstances, it's not necessary.
I think with my colleagues that share the transition executive level team with me, I think we all understand, what we need to do to make Orange more effective and more efficient. And I think that in many cases, those guidelines are written down for us, and we do provide daily and weekly and monthly reports, certainly to our principals.
Okay, how much time do I have, Chuck?
You have about 8 minutes.
Okay, so you have, I have in front of me the resource availability reports that go back to, I think we got them from September of last year, August of last year.
Correct?
You're familiar with these?
I am.
Do we have a copy for the witness? Perhaps you can, and I'm also, I can be confident that you have a working knowledge of these documents, right? Because they basically report on your responsibilities, right?
They lay out how successful we've been in terms of staffing bases,
Okay.
to the expectation, if you will, at that base, because they're not all critical care.
Okay.
And so it gives us a guide in terms of how we've been in terms of staffing to the critical care level, as an example.
Okay. So if we could just have a look at the March 2013 report, which is, I'm assuming, the most recent that we have. And if we go down to the middle of the page, it talks about the downtime reports. And if we look at the first column, it would be the Ottawa Rotor Wing Division, I'm assuming.
Yes?
And it talks about the number of hours that that base was out of service. And the total number for nights, I see there is 13%. So 13% of the time, the Ottawa base during the month of March was out of service. Is that correct?
That's what it's saying, yes.
Or is that, oh, that's days. That's right. So during the day, during the night, it would have been out of service 5% of the time. Is that right?
That's correct.
And then we go across Toronto during days, would have been out of service 4% of the time, 9% of the time during the night. We come across to Moosonee, it would have been out of service 19% during the daytime, 36% in the evening. And if we go to Thunder Bay, it looks like 81% during the nighttime, 2% during the day.
That's on the Thunder Bay Rotor?
That's Thunder Bay Rotor, right?
Rotor, yes.
So I'm looking at these same reports that go back to September, August of last year, and I look at those same numbers, and they're very close. For example, we have, there's about a 1 to 2% difference here in terms of downtime. It would have been 12% versus 13% for Ottawa, 5% versus 3, 7 versus 9. There is a significant improvement during the daytime in Toronto from 4 to 15%. The others are relatively close. The reason I wanted to get your thoughts on this, can you tell me what 1% represents in terms of the number of hours that a helicopter would be out of service?
I don't have that.
Translate that in a number of hours.
Yeah, what 1% would be, it would depend on, I mean, if you're staffing at 2,080 hours a year,
Yes.
work hours, I don't have the calculation before me what 1% would be.
Okay. I understand it translates into something in the range of 22 hours. And
Okay.
we can get those calculations. But nevertheless, it's a lot of hours that the service is not available. You've been there now for a year? Close?
In different positions.
And it seems as though there hasn't been a great deal of improvement on the frontline ability to respond. Can you comment on that? What is the reason for that? And what plans do you have in place? And how much longer before we can get to the point where we really can say that we have a reliability air ambulance service here in the province of Ontario?
I think as I look back in the rearview mirror and reflect ahead if I could, I think given what we were able to do over the last year under some pretty difficult sets of circumstances, under Dr. McCallum's leadership over the next year, I'm really feeling very positive about where Orange can go. And some of those complexities that I spoke of when I first came into the organization, because Orange was extremely complex. If I use an example of measuring it between, what I had under my command before at Toronto EMS, 950 paramedics versus 227 at Orange. That's the kind of complexity that I was able to look at. I think when it comes to the education of paramedics and the upgrade of paramedics, as I mentioned to you previously, we don't intend on hiring primary care paramedics at Orange any longer. We are working with our community colleges across Ontario to attract graduates of the advanced care level, the advanced paramedic program, and be able to train them up to Orange's requirements at a critical care level that much quicker. We're taking the process of critical care only from one that was well over 1 year to down around a total of 26 weeks to completion. The issue with paramedics and aircraft, they're totally different issues. Pilots and aircraft. They're totally different issues, especially when it comes to the north. I'm not an aviation expert. When aircraft are down and when aircraft are deemed to be down by pilots or captains of the ship, that's not something we question because safety is first and foremost. When it comes to pilots, I know we've had issues with pilots at various bases. As we made a decision to upstaff the rotor at the Thunder Bay base, our biggest and busiest base, we had issues. We knew we could staff almost immediately with paramedics, but we're in the process of attracting more pilots and training them up. Again, sir, don't think I'm any expert on aviation. I'm not.
We are out of time, so we'll move to the NDP, and you have 20 minutes.
It's a pleasure to see you, Mr. Farr, and also thank you for the most pleasant visit you helped organize for us last week.
Oh, thank you. It was a pleasure having you visit.
It was, I learned lots, and it was very well done, so I thank you for that.
Well, thank you.
The question I'm interested in knowing is that all of those reports we have in front of us, are those shared with people within the ministry?
Yes.
And how is that done? Do you fax them over, or once a month you send a pigeon over? How does it work?
I'm not sure, sorry.
No problem. But you know that the ministry is keeping an eye. Have they ever called you and say, oh, we looked at your report and we're happy, we're sad, have questions?
No, frankly, we get questions frequently. I wouldn't say daily, but a number of times a week we'll get questions on our performance and our staffing issues and pilot issues and so on.
And where would those questions, who would initiate those questions? And are they because they've received report? Is it because you flagged it for them? How does it work?
It's typically because they receive our daily reports or these kinds of reports that they're helping monitor our performance in achieving those targets that we've set out.
Okay, so you had talked to us last week that you have daily, then I think every 10 days, then I forgot the,
That's on the investigations.
oh yes, true.
The investigations were the 10-day and 40-day, and we do daily reporting to the ministry.
Okay, was this something that was always there, the daily reporting?
I'm sorry, I don't know.
No.
It's certainly something that was started up with the introduction of the Air Ambulance Oversight Office.
Okay, and so there are people at the ministry who review those, and every now and again, they have questions for clarity or question because they're not happy, or can you give me an example? When was the last phone call you got and what was it about?
It was about one of the questions that Mr. Klees asked me regarding pilot staffing, and I had to get further details for them.
Okay, okay. And you were able to answer their questions?
Yes, not immediately, but, you know, within an hour or two, we got back.
You got back? What do you figure would happen if they ask you, you know, like a question that doesn't put you in a positive light? You were not able to do X, Y, Z, and you didn't answer?
Well, I don't think that would be acceptable. They'd be looking for us to answer and be able to explain, you know, how we're going to improve that or correct that, depending on whatever the situation is. I think the oversight on us is much improved compared to where it was.
So even if that was not your best day, they were asking you about something where Orange really was not shining that day, you feel that you would still have to tell the ministry?
Absolutely.
Okay. And if you were not to do so, you feel that the ministry would follow up?
Yes, I do.
Yeah. And what leads you to believe that they would do that?
Well, I think it's the number of questions that we get now in terms of our performance. There's a lot of transparency in what we do daily, a lot of questions asked, and a lot of reports that we provide. And frankly, that's the way I like it.
So continuing on, you have questions coming from the ministry. They're not happy with the answers they're getting from you. Where do you figure they would go next?
Well, I think it's our job to, depending on the situation, the hypothetical question that you're asking me, I think it's our job to indicate to them why it's like that and what our plan is to correct that, whether it's short-term, long-term, if it is correctable, all of those kinds of things. I think that's part of our responsibility to them.
Okay. And you feel comfortable with having a responsibility directly to the Ministry of Health? Do you figure this is the way it should work?
Yes, I'm quite satisfied with the level of reporting that we have today and the accountability.
How does this compare to where you were before, when you were in Toronto, EMS?
It's very similar. We would provide daily operational reports to our city deputy city manager, our city manager, and certainly members of council and the mayor's office. We provided regular reporting in terms of our response time commitment and our targets, how we were doing.
Okay. So Mr. Klees, when he asked, wanted to see basically some of the performance measured directly into the performance agreement, but what you've said is that you have a deployment plan, and this deployment plan, I guess you have the flexibility to change it at interval as long as everybody agree with that plan. Is this how it works?
Well, we have the bases, as I mentioned in the presentation that you saw. We have those bases that we're expected to staff each day with pilots and paramedics and aircraft that are equipped and ready to respond. That's a simple process to say, but it becomes very complex to do when you start looking at, you know, the different areas around the province and issues in terms of maintaining appropriate staffing levels.
You can see that because of what happened, there's a level of nervousness out there. We want to make sure what had happened in the past, or what the ministry said happened in the past, is that they would call Orange and they would get stonewalled. Orange refused to give answer. Let's say you're not in there, but somebody else is doing your job and refuses to get answers to the ministry. Do you figure it's possible that somebody could stay in their job and refuse to answer questions from the ministry? You seem quite willing to work with the ministry and answer questions. The people that were there before, apparently, so the minister tells us, stonewall them. They would not answer their question.
No, I mean, as I said in my opening statement, I'm very, very proud of the efforts that the senior team is putting into this, and under the leadership of Dr. McCallum, it's only getting better every day. It's all coming together. I can't imagine anybody not responding to a request from the ministry or anyone else that's looking for information. It's a very transparent operation.
Okay, so if a new, you get to retire for the second time, and a new person comes in and stonewalls the ministry, what do you figure would happen knowing the players that are there now?
I don't think there would be any stonewalling. I think if there's a legitimate question put forward about Orange's operation, I think that everyone on the executive team, including the CEO's office, is going to do what they can to answer that question.
Okay. You've explained a bit to us as to how complex it is to deploy, the number of phone calls that needs to happen, and it was quite interesting when we did the tour, basically to see it live. To see, like the different pieces of the puzzle that all needed to be put together, and you had put forward for us a live scenario as to how this is done. That leads one to believe, though, that at any one of those action point, things could derail. I know that people have complained against Orange before, and certainly people have in the past complained about issues that have happened to Orange. If there is a complaint right now directly related to the people you're responsible for, how would that go?
Well, depending on how we're made available of that complaint, it would be investigated through our professional standards office internally. It might be the ministry that's asking questions. The ministry investigators might be looking at it, depending on the issue. But at every step of the process, we have things that are put in place to check and balance and make sure that things are going along the way that they're supposed to. And certainly the introduction, when you talk about the communication center, the introduction of the new automated system will make it much, much easier to make sure that things are done in sequence properly.
Okay, and if somebody has a complaint that has to do directly with your department, that has to do directly with what you do, would you be aware of it? Would it come to you?
Absolutely.
Yeah, it's handled directly by you?
May not be handled directly by me, but if it was one of my managers or one of my directors, they would of course let me know.
That there's something going on? Did you want to?
And we do regular reporting on the complaints.
Just one more. Since you're there, has anybody from the ministry gone to Orange, talked to you? Has anybody that works for the Ministry of Health gone to where you're working?
Yes.
Have you seen them there?
Yes.
Who was it and when?
Well, we get regular visits by the Air Ambulance Oversight Office, Mr. Jackson.
Okay.
He's in touch with us on a regular basis. And we have regular meetings with them in terms of our process and our activity, our operational activity in particular.
And do they come to you, or do you come to them?
Both, depending on the situation. If there's a need, we'll contact them and report something.
Okay. Jackie?
Yes, thank you, Mr. Farr. Mr. Farr, just wanted to confirm, so you're currently employed with Orange as the Vice President of Operations?
On a contractual basis, yes.
Okay. And
I'm not an employee.
You're not an employee?
Correct.
And your understanding is that the contractual basis, it's paid through by Orange directly? Is that what when you receive your payment or
That's
your
correct.
salary? Okay. And were you ever asked to disclose your salary or your remuneration to the Sunshine List?
I understand because I'm on contract, it's part of further disclosure, which I may be wrong. I believe it's disclosed sometime in June.
Okay. And would you have any problem disclosing that? You don't have to do it now, but in general, if if the ministry asks, or if anyone from the Sunshine List or the Ministry of Finance asks, would you have any issues disclosing?
Not whatsoever. I believe Mr. Klees asked me during the visit last week. It might not have been you, sir, but I think it was, and I disclosed what my earnings were.
Okay. And would you be able to disclose that now then, what your salary is, your compensation is?
Last year, from April 17th to the end of the year, 135,000.
Okay. And this year, roughly the same? Is that the expectation?
I have no idea. It depends on how many days I actually work, so. How long will they keep me? I'm not sure.
Fair enough.
Are you aware that the Legislative Assembly is discussing Bill 11, the Ambulance Air
Yes,
Act? Do you know anything about the bill?
I've briefly reviewed the bill.
Did you? Okay. Are you waiting with bated breath for that bill to come through so that you can do something that you're not doing now?
It's a difficult question to respond to. I think it's a very important bill, a very important piece of legislation. I think it's important to have oversight, but at the same time, I'm confident with where Orange is heading, and I think that the bill needs to be there, but hopefully Orange will continue to perform, beyond expectations that are there today, and will perform very well.
Okay. You say the bill is important for oversight. The first 10 minutes of our conversation was really about oversight, and you agreed that the ministry was doing quite a bit of oversight with the phone calls, with the meetings, with the reportings. Do you really see that the oversight will change with the bill?
Well, I think it's...
I can help you by saying that you seem to be doing a pretty good job now. I don't see how things are going to change.
Well, I guess from my perspective, if I may, again, I think oversight is important. We are spending the public's money, and I think it's important that, that government has a way of saying, yes, they have the oversight. From our perspective, I know, speaking for our senior team, we intend on doing things right, and we intend on making Orange a service that everyone in Ontario can be very proud of.
I think you're on the right way. We have a lot of the people who works for your department are the people that were whistleblower. It's because of what they did that we became aware of what was going on at Orange, and that things were put into place to try to improve, including recruiting you. Do you know if you have the people who did that, the people who blew the whistles, most of them lost their jobs, most of them were severely punished, and most of them paid a pretty significant personal price for having blown the whistle on everything that was wrong at Orange. It would have been different had there been protection. Do you know if you have whistleblower protection right now at Orange?
Yes, we do.
And how does it work?
Well, we encourage people to raise issues, particularly, what involves patient care and safety and all those kinds of things in their daily work environment. It's raised through a third party, and it's dealt with, in my view, quite appropriately, and they don't need to fear reprisal of any kind.
So right now, if they see something that is wrong, how do they know who to call? How do they know about this third party?
It's been well advertised across Orange. Employees should all be very well aware and exactly how to contact a third party.
And you yourself, do you feel confident that if you were to call this third party, that nobody would know that it was you who called?
I believe so.
Yeah.
I haven't called, but I believe so.
We'll test it. But you feel confident, and the people you work with, are they happy with your whistleblower protection, or do they feel that you got it right?
I've visited every base in the system except Moosonee, and when I talk to our frontline people, our pilots, our paramedics, our maintenance folks on our bases, I think people are really feeling quite confident about the future, maybe not as confident as I am, but they are feeling very confident. And I think it's things like that that help people give a sense of, that their opinion makes a difference.
That their opinion makes a difference, yeah. And because you've now implemented whistleblower protection, they feel that if things don't go well inside, they could go there and be heard.
Absolutely.
Yeah, okay.
Could you recap maybe the two or three?
You have 2 minutes left.
Thank you very much. So in the 2 minutes we have, maybe briefly, we can just recap the top priorities that you have moving forward in ensuring that Orange gets to the high level of performance that you want to see it at. What are some of the major priorities that you really want to work towards, and perhaps what do you need to achieve those priorities?
Well, I think one of the biggest priorities is the one I probably spoke the most of today, and that's the Operations Control Center to support their change and their ability to track our paramedics and pilots and aircraft around the province, so that we know that we're ready, we know exactly where everybody is and what their status is.
Okay.
From my perspective in paramedic operations, the ability to recruit and educate paramedics in a timely and efficient fashion, dipping into, as I said, the very fine community college system that's in place around the province, and taking advantage of those people and those programs, attracting them to come to Orange, and to be able to continue to have the confidence of the public that we're there when they need us, and the rest of the healthcare system.
And in terms of achieving those priorities, what do you think Orange needs to do, and what would assist you in achieving those goals?
Well, I think we're already doing it. I think we're already well down the road looking at the shorter term and longer term. The executive team working with our board has laid out a set of directions for the future. We know the various projects that we need to achieve and the time that we want to achieve those in. We are working on a longer term strategy, but in the shorter term, I'm very confident that's the right thing to do, to put Orange into a position that I want to see, where there's more of a sense of urgency, if you will, from everyone in the organization.
Thank you, and we'll move to the government then. Ms. Jasic?
Yes, thank you, Chair, and thank you on behalf of the government, Mr. Farr, for the tour last week. I think it was extremely helpful and gave us, certainly when we saw the dispatch center and all the various components working together, I'm sure that new software will facilitate as well. Now, I just want to get back to the performance agreement. Mr. Klees has raised that issue already. It's my understanding that even if it doesn't set some particular targets, that requirements to report on levels of care, staffing mix, availability of shifts, and so on, that's all part of what is required to be reported.
And we do report on those. And as I said, whether or not it's specifically laid out, I can't recall, depending on which piece of performance you're talking about, but many of them are laid out in the agreement.
And pursuant to the performance agreement, of course, we have the quality improvement plan. And I'm just looking at the 2012-2013 quality improvement plan, and understaffing and transport, it specifically lays out some objectives that relate, in fact, closely to the document that Dr. McCallum forwarded to us, that you have had a chance to look at. And so that the objectives around paramedic staffing are to ensure that each base has 2 paramedics with the designated level of care, even during off-service hours. And so, as a summary comment in this document, it says in January 2013, we reached this level of care target, i.e. 2 paramedics with the right mix of training and certification, 71% of the time. Again, Mr. Klees has alluded to the fact that he hasn't seen much variability over the time period that we have been given. But furthermore, in this document, it says our goal is to increase paramedic staffing and training to reach the target of 75% of the time by March 2013, and ultimately to exceed that target in future years. So I'm wondering, in your position, you've mentioned training of staff, you've got a number of initiatives on the way. will you be able to reach 75%? And when? When will you get that next batch of paramedics trained? Can you give us some sort of sense of the progress towards improving the figures that we see in front of us?
Yes, I'd be happy to. We're about to graduate a class of critical care paramedics and of some advanced care paramedics at the flight level, which is going to greatly improve our ability to meet those targets. They've been in training for quite some time, and they're ready for graduation over the next couple of months. So that in itself is a big step in the right direction. They will spread out across the system. They're all from various parts of Orange bases. And we will continue that process in terms of the upgrade education and the use of new students as they graduate in the spring from community colleges that we've been speaking with. We haven't exactly signed agreements, but we have been talking with 3 community colleges who have responded to us very positively about a process that we could put in place which will really expedite the training of paramedics that can perform their duties at Orange.
So is the ultimate goal to reach 100% in terms of this staffing?
Well, 100%, we talk a lot about that. Is it achievable? When you talk about things like performance and these kinds of targets, there's an awful lot of things that can get in the way, right? And so, you might be setting your goal a little bit too high depending on what you're talking about.
So what are the difficulties? I mean, staff are off sick. Can you sort of give us why we're not better? Like, what are the factors that have led us to this current 71% number?
Well, it has a lot to do with the placement of the bases and the staffing at each of those bases, right? We staff a base with 11 full-time paramedics, and they're on 4 different lines, or 4 different shifts, if you will. And so if someone goes off sick, someone injures themselves and they're missing from their rotation, depending on the part of the province it's in, it can be very difficult to backfill those individuals. Now, we do have part-time paramedics at most of our bases, and it's just a case of everything lining up in terms of being able to fill those shifts. That's probably the number one factor that is an issue when it comes to the staffing.
Could some of the paramedics be being trained to be upgraded to critical care or advanced care paramedic status? Or?
Well, we go through that process in cooperation with our unions, because it's part of our collective agreement in terms of how long people are in the organization prior to being trained up. And we're very aware of that, but we're also aware of the amount of time that it's taken in the past, and we're looking to implement more efficiencies in that entire system.
But some of the out of service, or the not the desirable service level being in place, could be because some are being trained. That would be...
Yes.
Yeah. Okay. You have had a great deal to do with paramedics, obviously, in your 39 years, and every organization has a culture, and we know that paramedics are often faced with critical incidents that, especially if it involves a critically injured child and that kind of situation, that it's a high-stress job. And I think we all acknowledge that, and this is why we value the work that they do. You arrived at Orange. I'm sure you met with paramedics. Can you get they knew that their organization was subject to a great deal of media interest. Can you sort of explain to us the morale of the paramedics when you arrived, and what you've seen over time since you've been there?
My heart goes out to them, because they sit down, particularly if you're one-on-one, and they open up in terms of the work that they're being asked to do, and yet they look at the walls falling down around them. And we've assured them that that's not going to happen, and we're all hopeful of a better future. And you just can't blame paramedics for the way that they feel, and that in fact affects pilots in the same way. People that are at our base locations, as well as our maintenance staff that are at those locations. So everybody's affected in the same way. But your point about paramedics, yes, they're expected to perform, you know, at their utmost best, as are the pilots, and you want to keep everybody as sharp as possible. You don't want them to be affected by all this other parts of this issue that are all around them. We've spent a lot of time, as I mentioned to you last week during your visit. I'm very pleased that our new leader, Dr. McCallum, has been out at almost every base. He's had a lot of face-to-face visits with the staff at the bases. They've heard from our new leader, our new chief, if you will, in terms of the direction that he sees and his vision for the future, and I'm hearing a lot of very positive comments back. We've been trying to do that a lot over the last year as well. As I indicated, I've been at every base except Moosonee, and people are just more than willing to sit down and talk about what we see for the future and where we're going.
Yeah. Well, I think in terms of restoring public confidence in the air ambulance system, the type of work and the face-to-face time that you're spending with the medics is obviously going to go a long way, because they're going to be able to project that kind of confidence in the system going forward. In terms of the staffing, so you're making all this effort in terms of the training, hiring, community colleges, and so on. How do you see the mix going forward in terms of critical care versus advanced care? What would be your sort of ideal staffing mix to properly serve the people of Ontario?
I wish I had the answer. I think it's one of those projects that we want to get into in terms of a detailed review of the level of care requirements across the system. You know, because we're striving to staff to the critical care level at all bases. And, you know, we've had many discussions amongst the senior team to look at how and when we could actually take a more detailed review. You know, our experience in the number of times that paramedics utilize their skills in various calls that they're doing around the province, you know, it helps sort of point us in that direction, saying that, you know, what level of care should we have and how should we best deliver it? Helicopter, fixed wing, land vehicle, etc. So I think all of that needs to be part of a future review internally in terms of giving us that information on a go-forward basis.
Other issues related to paramedic morale, that infamous interior of the AW139 that was not functional in terms of life support and so on. Can you just go through again exactly what has been done in terms of that interior and how the paramedics are working in that environment?
Well, again, we took a lot of what our paramedics were telling us and we implemented into what we call an interim interior. That's been installed in all of our AW139s. Of course, that didn't affect the Sikorsky fleet. We've implemented it across the system, and the paramedics have been very quiet on that issue. I think the paramedics that I'm talking to are quite satisfied with the changes that have been made, and we haven't given up on that. We still listen to the paramedics. We still look at the EMS industry as a whole. And I think, as you heard from a few of us during your visit, that we're still looking at other ways to improve and hopefully get to the total roll-on, roll-off system from the AW helicopter.
And since I have more time, could you expand a little bit? One of the Auditor General's original reports was a request to look at the interface between air ambulance and critical land ambulance. And could you just expand? In your opening remarks, you just mentioned that study that's being done, but perhaps you could tell us more.
So that review is underway by Deloitte. Over the last few weeks, they've been visiting our bases in Ottawa, Markham, Peterborough. They have met with the team, the leadership team and the paramedic teams at Toronto EMS, who also operate critical care land. And they have interviewed a number of folks at Orange's head office in terms of the data, the finance side, and so on. So they're going through the process. And I think that so far from what I'm hearing from them, they're pleased with what they're seeing.
Right. So they'll come out with some recommendations if there's potentially a shift in location of base, land ambulance, or whatever mix might be potentially more appropriate. Or...
I would expect you're right. I would expect that they will produce recommendations and provide them to the ministry in terms of moving forward.
Well, on my behalf, I certainly find everything you've said very reassuring. Do either of my colleagues have any further questions?
We are similarly reassured.
Thank you.
Thank you.
Mr. Chair.
Thank you very much, and thank you for coming in today. It's appreciated.
Oh, thank you very much.
There's 6 minutes left. If you mind, if Mr. Klees is...
I might want 2 minutes more.
Okay.
Can you
Oh, no, I'd like to take the advantage, if we could, Mr. Farr.
Mr. Klees?
Yes, thank you. You were how many years head of EMS at Toronto?
In the chief's position, sir?
Yes.
About 8 years. I was promoted to the position right after SARS, and I was in the position of chief until I retired in February of 2011.
Okay, so during that time, who at the Ministry of Health did you have interaction with? Was it the Emergency Health Services branch of the ministry?
That's correct.
And was there someone specifically that you would liaise with?
Well, there was a number of positions. Toronto EMS it is the largest municipal land service, and so it's also got its complexities, but dealing with the ministry, depending on the issue, if it's an operational issue versus a staffing versus a finance issue, there'd be different people that we would deal with. I typically would have dealt with Malcolm Bates at the Emergency Health Services.
And Malcolm Bates, of course, was also at one time responsible for the air ambulance service before it was transferred over to Orange. Have you had any discussions with Malcolm Bates about Orange since you took on your responsibility?
On a few occasions, Malcolm's role was to be part of the steering committee on the land review.
Yes.
And he has since retired, so he's not in that role any longer, but we had some brief conversations leading up to that.
When Malcolm Bates testified at this committee, he indicated that the ministry was actually directed not to interfere with the operations at Orange, notwithstanding that they knew there were some problems there. Did you at any time sense that the ministry would hesitate contacting you if they felt that there was an issue in your service? Did you ever feel that there was any concern that they would be overstepping their bounds, or did you feel that the ministry was on top of their job when it came to their oversight responsibility of Toronto EMS, for example?
Well, in my situation as the head at Toronto EMS, relationships were the most important thing for me, and I had a good relationship with the folks at the ministry, and we worked well together. That's the position I'm in today at Orange. We're building and strengthening relationships across the system, particularly with our EMS partners, as we look at how we can work better with them to provide service to our patients and the citizens across the province. My relationship with Malcolm Bates was very professional, a very strong relationship over the years. We had to go to that office for approval of our deployment plan and our budget that we were putting forward to the city and so on.
Thank you. And France, did you wish to use a couple more minutes as well?
I'll leave him finish his sentence, then I'll
Okay.
jump in.
Okay.
I was just going to ask, how many surprise site visits has the Ministry of Health made to Orange since you've been there?
I'm aware of two.
Two specifically?
It could be more, but I may or may not know about them.
Okay, and the nature of those were what?
where they dropped in on 2 of our bases at different times.
Okay, thank you.
I just, when you first were called to work at Orange, you were not in the position of VP of Operation, am I correct, or?
That's correct. I started as a special advisor to operations.
Was Steve Farquhar still VP of Operation when you started?
Yes, he was.
He was, eh? So are you assuming the same role and responsibility that Steve was when he was there?
Yes, I do. I am.
You are. Do you know where he's gone?
He left Orange, and upon his departure, I was asked if I would step in and fulfill the role until the job is filled, and we have plans on doing that in the near future.
Okay, and so there's a plan to post the position as a full-time position at some point in the
Correct.
near future?
Correct.
Okay, all right, and you mentioned that Mr. Farquhar left Orange because his contract was over, or because he decided to go someplace else, or do you know anything about that?
I don't know the details, but he left Orange.
Or he left, okay, thank you.
Thank you, and Ms. Jazzy?
Well, since there have been some questions related to your relationship with the Ministry of Health, at the moment, the head of the Orange Oversight, or the Air Ambulance Oversight Unit, is Mr.
Richard Jackson.
Jackson. So what sort of, since he took over, how do you relate to him and his unit, or do your staff? Can you just sort of give us a sense? We've talked about daily records going in, but how would this look? You were presumably involved in preparing a budget, etc. So could you just sort of lay out what the relationship looks like now?
We have, I in particular, have regular opportunities to speak with Richard, having to do with a number of projects that I'm working on, but also the daily operations component, because we do send a daily report that he reviews each morning, and he may, in fact, either phone me or send me an email back with some questions on that report, and we respond appropriately. So, yeah, we do have a regular interaction, if you will.
Were you involved in the formation of the next fiscal year's budget in your role as VP?
In certain parts of it, it was kind of during the transition time that we were speaking about in terms of Mr. Farquhar's departure and my taking over the position. There was different parts of the budget planning that was going on.
And this was in consultation with the ministry?
Yes.
Yes. Thank you.
Thank you, and thank you very much for coming in today. Appreciate it.
Thank you very much.
And our next witness is Denise Polgar, patient advocate for Orange. Welcome.
Hi.
And I just wanted to confirm that you'd received the letter for a witness coming before the committee.
Yes, I did.
Very well. And
Swear an oath.
clerk has an oath for you to swear then.
So, Ms. Polgar, can you just raise your right hand, please? Do you solemnly affirm that the evidence you shall give to this committee touching the subject of the present inquiry should be the truth, the whole truth, and nothing but the truth?
I do.
Thank you.
Very well. And did you want to make an opening statement?
I have one, yes.
Okay, very well. Please
Thanks.
go ahead.
Good afternoon. My name is Denise Polgar, and I am the patient advocate at Orange. Thank you for the opportunity to speak today. I'd like to begin by spending a few minutes explaining my background, my role within the organization, and what we are doing to better serve those who matter most to us, our patients. Let me begin by telling you how I came to Orange in the first place. In many ways, this position brings together a number of skills I have gained over the course of my diverse career that has focused solely on healthcare. I spent 10 years as a primary care paramedic with the County of Brant Ambulance. This position naturally gave me frontline experience in treating ill or injured people in a mobile environment and ensuring patients got to the care they needed in a timely fashion. From there, I worked as a communications officer in the London Central Ambulance Communications Centre. Like their paramedic colleagues working in the field, a communications officer's job is demanding and challenging, involving complex logistics under stressful situations. I also functioned as a training officer in this environment, which involved preparing trainee dispatchers in multitasking, critical thinking, and decision-making in simulated and production situations. Later, I worked as a program coordinator and instructor with Fanshawe College, where I designed and implemented curriculum for the emergency telecommunications program. From there, I entered the hospital sector, most recently as an injury prevention specialist at London Health Sciences Centre, concentrating on the development and implementation of injury prevention priority programming that was led by the trauma program. In sum, I have worked in pre-hospital care, communications, education, and the hospital setting, all aspects which you will find within Orange. I spotted the posting for patient advocate over the summer of 2012, and it immediately piqued my interest. Like many in the healthcare sector, I had been following Orange in the news and thought that it would be an exciting and rewarding to play a role in the rebuilding effort for the organization. The opportunity to play a role in having regular interpersonal interactions with patients to help improve their experience is what this position truly made it enticing. The ability to get back into emergency health services and utilize my healthcare experience to help facilitate patient and family concerns was a perfect balance for me personally and professionally. I believe that having a person dedicated to handling patient concerns, questions, and feedback who is committed to ensuring the organization is acting in their best interests is essential in any healthcare setting. The position of patient advocate is brand new to Orange. In fact, it may be brand new to the field of air medical transport. We have not been able to find any similar organization to Orange with a position like mine. While we are breaking ground in this industry, it is worth noting that there are patient relation departments working at hospitals across Ontario, and we have consulted with many of these facilities for guidance and advice in developing this role within Orange. I personally know and have interacted with a number of patient relations specialists at hospitals across Ontario, and I feel this is an important role at any facility. I was honored to have been offered the position of patient advocate, and I began this new role in September. In the most straightforward terms, I'm here to serve our patients. Every day I interact with them. We speak on the phone. I answer their emails. Sometimes they are unhappy with our service. Sometimes they want to express thanks to the crew that provided transport to their loved ones. Sometimes they simply want to ask questions to get a better understanding of how our system works. Whatever the case may be, all of this feedback is directed my way. I track the complaints, liaise with the patients and their families, facilitate the process of providing information, and ultimately work with patients to resolve issues. At all times, I try to put myself in their shoes, imagining the initial anxiety of going through a serious illness, followed by the added stress of requiring transport to a hospital that's hundreds of kilometers away from home, and ultimately not knowing what the outcome of their loved one may be. What would my expectations be for the care of my family? What would I want to know, and how would I want to be treated? I'm also mindful that the foundation of my position, which is Orange's Declaration of Patient Values. It is my job to make sure that the organization upholds this declaration. These values were not chosen at random. In fact, they came directly from our patients themselves. Orange surveys patients on a quarterly basis and uses the results to identify what the organization is doing well and what needs improvement. Descriptive comments from last year's surveys were used as the basis for the first draft of our Patient Declaration of Values. Patients were then asked to rate the importance of each of the proposed components. Based on their feedback, a declaration was established that I would like to share with you now. It reads, as a patient being transported by Orange, it is important to me that, 1, I am safe from harm in the care of competent, highly skilled staff who provide excellence in my medical care. 2, the urgency of my transport will be prioritized according to need. 3, state-of-the-art technology and equipment supports my care. 4, staff respond to my anxieties, fears, concerns, and questions in my time of need and in unfamiliar environment. 5, the experience is well organized and seamless. 6, the environment is clean. 7, my family are involved in care and receive timely communication regarding expectations and responsibilities. 8, my comfort needs are met. 9, I receive compassionate, kind, and considerate care by professionals who respect my privacy, religious, and cultural background. And 10, I receive information on the plan and any changes during transport. This declaration is posted publicly and demonstrates the commitment to patient care that we all share within the organization. I want to stress that while I work mainly with patients and their families, I am one part of a larger team that addresses concerns over Orange's services. If an issue is more serious or involves a more formal examination, I work with Orange's internal investigations team, which in turn is in frequent communication with the Emergency Health Services branch of the Ministry of Health and Long-Term Care. I am also frequently in receipt of feedback from other stakeholders, such as healthcare providers, and I will take the responsibility of directing them through the proper channels. Orange also has what's known as a care report system, which documents internal and external complaints. I can't speak too much of what took place at Orange prior to my arrival, but I am aware that Orange did not have one central person responsible for interacting directly with patients. Feedback from the public came in to the organization from a variety of different venues, without one person taking ownership of making sure concerns were addressed consistently and timely. Because of this, complaints and concerns were frequently lost in the mix, resulting in lengthy delays in responding to our primary stakeholders, the people of Ontario. This is not acceptable, and I have worked hard to streamline the complaints and patient relations process to allow people to easily access it. On top of that, we have guaranteed a response acknowledging their comments within 2 business days of receiving them, with an assurance that their concern will be taken seriously. Also, prior to my arrival, Orange did not have a central functioning electronic system for tracking and categorizing feedback. Putting such a system into place has been one of my top priorities since arriving at Orange. This system will allow me to keep an eye on emerging trends and to be able to identify, report, and advocate for operational improvements that need to be made. This is an ongoing, long-term goal. In addition, I recently provided the first of my reports to the Orange Board of Directors, which I will be providing 6 times per year. Because this position is new, it is constantly evolving, and I look forward to see what additional steps can be taken to make sure the best interests of our patients are being looked after. In conclusion, I want to remind everyone that Orange transports more than 18,000 patients per year. While we'd like to hear from all of these patients or their families, only a small fraction of these patients will get in touch. But when they pick up the phone or type an email with a concern, question, or general feedback, they should expect to be listened to. That is why I'm here, to listen, to discuss, and to facilitate, in the hopes of making their patient experience as compassionate and professional as possible. Thank you.
Thank you for that opening statement. We'll go to the NDP. Ms. Jelinek, you have 20 minutes.
Thank you. It's a pleasure to meet you, Mrs. Polgar, and thank you for your opening remarks. First, could you just give me an example of a call you took recently? But don't share anything we're not supposed to know, but just an example.
I recently received a complaint from a family in regards to medical protocols that were done on their loved one.
Okay, and
That was just yesterday, so that's the minimal amount of information that I have.
okay, so take me through some of the steps that you would go through.
I got a voicemail, so I returned that voicemail to the family. I get further details from the family as to what the complaint is, what their expectations are, and to determine what steps need to be taken in order to find out the answers for them. From that, I describe the process of the complaint and how that works with what we will do in order to look into those details. I then enter that into our electronic tracking system with all of their contact information, the basis of their complaint, and then that is then activated once I do that to various people in the organization, our investigations team, our VP, Director of Operations, so then they're aware of it. And then from there, that starts the ball rolling in determining what actions or investigations need to take place depending on the complaint.
Since in the short time that you've been there, I realize you haven't been there for years and years, has there ever been a complaint where after you tried your best, the family was still unhappy?
I haven't had that happen yet. However, when that does occur, if we've gone through the process of follow-up and the family has further concerns, we'll then go back and find out additional information. From there, if they are still not happy with that process, I would then take that to the Board of Directors for consultation to find out what decisions we need to make. Potentially, did I say to the Board of Directors or Executive Team? Both.
Okay.
I have the option of doing both. And obviously, the ministry may or may not be involved in that time, and I would then notify them as well.
Okay. The process you've just explained to us, that particular example, looks very much like what they do in the hospital. They don't always call them patient advocate, but it sure feels like it's similar. Would you say that it is similar?
We have modeled this process from patient relations departments in hospitals. So I would say that we mirror what they are doing, and we're learning a lot from them. We have some unique aspects within our organization, but that is the model that we're using and that we're learning from.
Okay. Because you're under the Ambulance Act rather than being under the Hospital Act? It brings...
And their patient relations are dealing solely with the patients themselves. Right now, I'm fielding complaints from others as well. Patients and families always take priority. They're always who I deal with first, but I am fielding other complaints from stakeholders, from communications centers, other healthcare, not a lot, but some healthcare providers, and our hospitals as well.
Okay, okay. I thank you for that. I don't know if you know, but with the process that exists within our hospitals, and you're following something quite similar, there are hundreds of people that are not satisfied with, like the best answers that they're getting from the patient advocate. Those people tend to turn to the ombudsman because the ombudsman is an independent third party that can do investigations for them. In the process of a patient and family working with the patient advocate, sometimes what happens is that they lose faith in the hospital that did not treat them good, so they started to complain. They deal with the patient advocate who could be very skilled at what they do, but just cannot help this family turn the page, and the process ends. At some point, the communication is the hospital has done as good as they can. They've given them everything they could. They try to accommodate them as best as they can, and some of the patient's advocate have years of experience and are really good, but there's still some that are not satisfied, and those people turn to the ombudsman. Do you see a role for something like this for Orange if it ever happens that it doesn't matter all your experience, your skills, your goodwill, and your directive, that if a family is not satisfied and turn to the ombudsman, that they could have the ombudsman do an investigation for them?
The first thing that comes to mind is we internally would like to exhaust all
Of course,
opportunities and go through all the appropriate leadership channels to see if we can resolve the issue with the family. And then we would also work with the ministry and their guidance for suggestions and recommendations that could be changed depending on the complaint. As for the ombudsman, I would personally be happy to have any help that has to do with improving the patient experience if the policymakers feel that that is something that needs to be done. So if that is what's deemed as appropriate, then I would work with that person and any department that could help improve the patient experience.
Okay, did you want to go now, or? We'll let it go around, and we'll have our second round of question after.
Okay, very well. We'll move to the government then. Ms. Jasic?
Thank you. And Ms. Polgar, just to get back to some of your experience, originally a primary care paramedic?
Yes.
And then moved, was it to dispatch? To
Yes.
That was in London? Was it?
Yes.
Yeah. So I'm just trying to sort of get from your background. You have a very good understanding then of certainly of land ambulance, of all the steps in the process in terms of whether it be interfacility transport or whether it be from a scene to an emergency room and so on. Would you say that's fair, that you understand the system?
I understand the system, but I think Orange has some unique aspects that I'm learning about every single day that differentiates it a little bit, but the basis of emergency medicine, yes, I would.
What actually, that intrigues me, what is so unique about air ambulance?
I'm honestly still learning how that works, but even with the triage process, they have transport medical physicians, which is a whole new world for me to understand in the communications center. The resources, the time that it may take to do one particular call, the matrix of the paramedics and the levels that they have and how that works, all make some of those things unique that I'm still learning.
So they
about.
actually, in essence, they have some additions. When we went on our tour, I hadn't been aware that there was a 24/7 physician sitting right there in the dispatch. So
Yeah.
the sort of intensity of and concentration and focus is a bit beyond what I'm used to in terms of the land ambulance system, and so that no doubt does provide extra, as you've said, issues potentially for you to deal with. You do have a background in teaching and education as
I do,
well.
yes.
And have you found that helpful in terms of your role as patient advocate?
I think all of that, I've taken a little bit from every little part of that to help me in this role right now. Getting reintegrated into health, back into the emergency services, is going to take a little bit of time. There's a lot I need to study. There are new people that I need to meet, relationships that I need to build, and a better understanding of that happens every day. And with every complaint that I deal with, I learn a little bit more.
In terms of the complaints that you're dealing with, as we know, Orange deals with many interfacility transport. Could you sort of give us some numbers? How many are related to sort of almost routine transfers? How many are connected to emergency on scene? How many are from some of these other stakeholders that you've mentioned? Could you just give us sort of a breakdown with some numbers since you started, what we're dealing with in terms of numbers of complaints?
With complaints?
Yes.
I've started tracking data in that electronic program. There's more opportunity to add additional fields to break down, are the bulk of our complaints coming from interfacility transfers or emergency transfers? That's not something that I've done just yet, but we have been tracking who does the bulk of the complaining and has issues with our service, and I think it's important for me to also say that I don't think I have an accurate number at this point, because they used to come in on all different kinds of venues, and as my role increases and people are more aware of what I'm doing, that's starting to be filtered, but I don't think that my numbers are perfect. But it really actually is our stakeholders that have the bulk of concerns with our care.
Rather than patients and families?
From the last information, a report that I provided to the executive and the board of directors, 12% came from family and 12% came from the patient, 7% came from the family, 50% came from our stakeholders, and whatever's left there actually came from the general public.
I see. So, your position in Orange is well known to the whole organization, I assume, like the paramedics. I mean, there was an announcement, I presume, when you started, or?
Yes.
Yeah. So, because you said now your office is becoming better known, your obviously calls are coming directly to you.
Yes.
But I presume everyone in the organization has the ability, if they hear of some sort of rumbling or unhappiness in general, that they know that you're there and they direct people to you. Would you say that's sort of the feeling that you're getting, that
Yes.
you're hearing from people?
I'm hearing from people, and to the point where they may call me and even ask, is this something that you should be dealing with, or is this something that we give to you?
Yes.
You know, so sometimes it's just general questions, but yeah, I would say every day that that's increasing and getting better.
What I'm trying to get at here is sort of a culture of openness, of addressing issues. Would you say that that's the way you're finding it now that you're there in Orange?
I actually think that there's some relief by the staff that my position is in place so that I can handle that properly and through the proper processes. So I have had nothing but transparency from everybody within the organization.
Of all these complaints that you've had to date, how many or what percentage have you perhaps not been able to resolve?
We do have open cases that are still continuing. I'm just starting to track the satisfaction from the stakeholder or the family or patient, and it hasn't come about yet where they haven't been pleased with the outcome yet.
That sounds very positive. Now, you mentioned developing your program, your role, very much modeled on what we all know is available in hospitals, patient relations, and so on. In terms of that process, can you just sort of outline to us how that worked, how you modeled your position on their process? I mean, you've talked about tracking and so on.
Yeah.
We know hospitals do patient surveys. Was this part of what you instituted? In other words, just sort of lead us through the parallels between the two.
Okay, so yes, some of it was developed by the surveys from the patients with the feedback that they've been providing. We also use a process map, similar to what the hospitals use, to help direct us, depending on what the issue or complaint is, on how that process is going to work. That process was developed before I came, and then I have been asked or consulted with the executive team on what that process, if there needs to be additional changes, but it's very much modeled by the hospitals.
Yeah.
Yes.
Thank you. I just had a couple questions. I was trying to follow your answers. I don't think we got a number on the volume of calls you feel. Would you be able to
Sure.
give me some idea on a monthly, weekly?
When we started the electronic program was in March 2011 to March 2013. All the numbers altogether, compliments, complaints, and inquiries, because there is a distinction between them, has been 246.
246 over a 3-year period.
Yes.
Okay. And I was very intrigued by the fact that I did a quick math. 80% of the calls or requests that come to you are not patient-related, because 12% are patients, 7% is family, so that's about 19%. 50% is stakeholders. And then the balance, 30%, is the general public.
Yes.
So given that 80% of it is non-patient directly, I'm just curious, given your position as a patient advocate, how does this 80%, how do you deal with it? Or do you find that the calls are invariably or mostly still patient-related? I'm just intrigued by the numbers and the breakdown.
Some of them are patient-related, some of them aren't, and we are working with the executive to determine the extent of my role with the stakeholders and what that means. But at this point, I'm able to review the incident reports and see if there's any opportunity for a systems improvement when it comes to those complaints that are stemming outside of the family and patient area. Does that answer your question?
Not quite. So I'm just trying to get so the stakeholders, when they call you, they're calling you on behalf of patients or with their own concerns? So are you sort of become a patient advocate, come stakeholder advocate? That's what I'm trying to figure out.
Sometimes the stakeholders may have a concern about a patient, sometimes it may be completely non-related.
And you're
to a
able
patient.
to respond to stakeholder concerns even though they are not patient-related?
I'm able to facilitate the process. At this
Okay.
point, that's what my role would be, is to facilitate the process, activate the proper process, and get the appropriate people involved.
My second question is, when you were answering Madam Jalanas, you gave an example of a patient call which was of an operation or procedure done on a patient by a
Yes.
family.
Yes.
Would that procedure have been done on an Orange plane, or would it have been done at a hospital?
For this case, it was done at the hospital.
So I'm just curious, why would the call come to you and not to the patient advocate at that hospital?
Because they questioned our medical protocols and what the crew was doing while they were getting the patient ready for transport.
So you have well-defined protocols to ensure there's no duplication between what a hospital advocate would be doing and what you as a patient advocate at Orange is doing. That's
Right.
what I'm getting from your answer.
If there is question about something that the hospital has done, then we could work with the hospitals and their appropriate leadership in the entire complaint process, depending on what that complaint is. So, for example, I have dealt with a hospital up in the north when it came to deciding or determining if a patient was eligible for transfer. So it was literally a teleconference between our communications center leadership, the hospital, and ourselves to discuss that and come to a consensus together on what was best for the patient. And then it hasn't happened yet, but tomorrow we have that teleconference to provide those findings with the hospital, myself, and the family.
Okay, thank you. Any questions?
We'll have some more, but I think we...
Very well, we'll move on to the opposition then. Mr. Klees.
Yes, thank you. An interesting responsibility you've taken on. Can you tell me how you were hired? Was there an open competition for the position?
There was an open competition for the position.
Okay.
I found it online. So I had 2 interviews. The first interview was with Human Resources and the VP of Clinical Affairs. And then the second interview was a larger panel that also included the interim president.
Given your experience professionally as a primary care paramedic and the other things that you've done, how much input did you have in actually shaping the role itself?
There was a framework when I first came into place. However, I am finding that leadership and staff are open to suggestions. Like in my opening statement, I talked about having a system to electronically track and analyze and then report on the data was my recommendation. And then improving our timeframes was also my recommendation. So I have found that they've been very open with evolving the role and improving it.
Your experience as a dispatcher obviously places you into an excellent position to evaluate the improvements that would be needed in order to make Orange 24/7 ready. I can imagine you being on the front lines. There can be nothing more frustrating than to dispatch a call and find out that a crew isn't ready, that equipment isn't ready. And from what I read, one of your responsibilities is to make recommendations. And so my question really is twofold. First of all, are you engaged at this point in terms of liaison with dispatchers in your communications center to get some input from them in terms of how things are going, or are you picking up from some calls that you're taking as the patient advocate that continues to be an issue? And finally, when you receive those calls, have you been able to have some input to management on areas that you feel can be improved?
Let's hope, I think you asked me 3 questions, so
I did.
just let me know if I don't answer each
Okay.
one. Okay.
I'll keep track.
Okay. My focus right now has been on getting a system in place in order for me to be able to track and then analyze what those issues are. Without a program of that nature, I won't be able to provide the facts and reveal things that are of issue in our organization. And my other has been working on timeframes. And what I mean by timeframes is not call response timeframes. Timeframes for us in order to get back on the complaint or follow up and the resolution process. So sorry I didn't specify what those timeframes may be. When it comes to systems improvement, quality initiatives, that's a long-term goal. So once I'm able to analyze that information and report on it, I'll then be in a better position to provide those suggestions and recommendations moving forward.
Okay. We have, as part of our volume of documents here, one particular document that caused us a great deal of concern at this committee, and that was a number of incidents. It was an incidents document that was a cabinet document presented to cabinet monthly, from what we understood, that listed numerous incidents that were reported in which Orange was not able to respond. Or Orange responded and they weren't able to take the patient on board because the paramedics declined them because they were single-staffed and they weren't capable of taking them on. Or incidents where the communications or the dispatchers got it wrong and weren't able. So my question to you is this: since you've been in your position, of the 246 calls that you've had, have any of those calls involved similar incidents? And let's deal first of all, have there been any incidents where a patient was not able to be taken on the aircraft because of whatever the circumstances were?
Okay. From those 246 complaints, I've only been part of a fraction of them, so they occurred before I came into play. So I can't recollect from those 246 what the findings were from all of them.
So the 246 are not the ones, you haven't been there for all of those 246?
No, that was
Okay.
from March 2011 to March 2013.
Okay. From the time that you were there, my question is, did any of the calls that you're familiar with, because I'm assuming that all of the calls in the time that you came on are now coming through you?
Yes.
You see them all.
Yes.
Did any of those calls involve circumstances where a patient was not able to be taken on the aircraft because of single staffing or any other circumstances as we've had in the past?
I'm not recollecting any specific complaint about staffing and them not being able to go, but maybe this will help you a little bit. There is, I have been tracking what the complaints are in categories,
Okay.
and our two major concerns are delay in communication.
When you say delay in communication, so that we understand correctly, that would be a delay in communication on what end? Is that from the time that Orange gets the call to the time the call goes out? Or please help us with defining that.
Delays may be time to get to the sending facility. It could be time on scene, so how long they're spending in the hospital. And then the communication may be that the stakeholder was not provided an update with when we would be arriving, or something to do with medical care. There's been a variety, and I've actually been asked through our executive team to break that down even further, so that's something that I'm going to start tracking in the future.
Okay. Do you provide a daily, weekly, monthly report to your executive team?
I just got approved to provide a report to our executive 6 times a year, or as required. So if there is a complex case where consensus cannot be reached, I can call upon the executive to meet and get consultation from them on further action.
6 times a year seems not a very not a very frequent reporting time. I mean, if I was on the executive of this organization, knowing the history, you know, seriously, I'd be asking for a weekly report from you so that I could properly monitor the progress. I'd like to know what the complaints are,
Yes.
how they're going. But that's interesting.
Something I didn't include was that I do have a weekly meeting with my VP as well.
And your VP is?
For Clinical Affairs, Joanne Oak-Vecchiato.
And so do you provide her a written report every week?
I provide her a summary sheet of outstanding complaints or inquiries. That includes some information about what the complaint is and where we are in the progress or the process.
Okay. Could we get a copy of those weekly reports that you're presenting to your VP?
I think the only thing that would concern me is patient confidentiality, because those reports have patient names and confidential information on them, but if I'm instructed to do so by the powers that be, then...
We're happy to have the names redacted. That's not the issue. I think what is important for us is that we know what the flow of information is and what the nature of that information is. We don't want any personal health information, but I think it certainly will give us a sense of what is in place to have that information flow. Can I ask you your opinion? So far, you've been there now a few months. You've made some reports. Obviously, some of them I would think, with your background, would be concerning. Delays, all of these things impact on patient outcome. Can you share with us an example of an incident where, as a result of input that you've had, where you have made a recommendation as to an operational change or a system change that would prevent or would help fix what's wrong?
The one case that sticks into my mind is I got a call from a family concerned that they weren't eligible for transfer under our criteria. So I then had conversations with the hospital to discuss the patient's current condition, what's happened in the past with our communications center, what were they told, and from that was able to agree with our communications center that this patient was eligible for transfer, and the next time that she has a treatment set up for a treat and return, that she will be transported by Orange based on her current condition.
Good.
And sorry to interrupt, Mr. Klees, but just for clarification for our clerk's sake of what you were asking for from the...
Yes, I was asking for the weekly reports that are being delivered to the Vice President of the incidents that she's received in the course of that week, from the time that the witness took on her responsibilities there.
Fine, and if I understand correctly, with the personal health information
With
redacted.
the personal health information redacted, and the names. Right.
And the names redacted. Okay.
Vice President, Clinical Affairs.
Okay, very well, sorry for the interruption.
Am I finished, or were you just interrupting me?
I was just interrupting.
Okay. Can you, apart from I'm assuming hospitals are one of the stakeholders?
Main stakeholder.
The main stakeholder from whom? Any other stakeholders that you're getting calls from?
Sometimes through the complaint may come through in an electronic form. So sometimes we may receive complaints from local EMS services as well.
Okay.
But it's mainly hospitals that tend to use that form.
And the nature of the complaints that you would be getting from local EHS would be what?
They may question the priority of a call. They may question a delay in response. Just off the top of my head, those are a couple things that they may complain about.
Okay. You indicated that you can report to the executive team and/or the board of directors.
Yes.
And is that at your will? Should you feel the need, you can make that appointment and be there
Yes.
to report?
It has been communicated to me many times that I have access to the executive team, the board of directors, and the president with an open door policy. If I have any concerns that need to be addressed, or we've reached a stalemate or have stalled in the process of dealing with this complaint. At no time have I felt that I don't have that option when I need it.
Good. That's very positive. Paramedics, have you had occasion to take any calls from paramedics on any matter?
At this point, it's professional practice standards that deals with complaints from paramedics that are non-patient related. So if I even did receive a call, I would then forward that to professional standards department.
Okay, and if the paramedic felt that it was an incident that involved a patient matter, they couldn't call you, you would...
They could.
They could?
Sure,
And you
they
would accept their call?
Absolutely.
I'm trying to get a sense of whether people get channeled where they don't want to be. If they say to you, look, I really would like to talk to you because I think I'll get a hearing from you, you won't turn them away?
Absolutely not.
Okay.
But we do have, like I said before, I'm one part of the system. So even if a complaint comes in, it activates more than just myself. So even if they called somebody else and it went into our system, I'm immediately alerted of that issue, and I can get involved if I feel it's a patient care issue or something about the patient experience that can be improved.
Okay. Back in June of last year, Orange was about to request a lowering of standards from the Ministry of Health. And specifically, it had to do with the issue of a single paramedic response or the type of paramedic qualification that could be on a flight. The rationale for Orange at the time was we'd rather make a flight with unqualified or lower qualified paramedics than not being able to make the flight. My understanding is that that didn't happen at the time. We challenged the minister on it. We know that the application for that watered-down standard had been prepared. Are you aware of anything within Orange that is in the works now? And is that something that you, with your background as a paramedic, and certainly the work that you're doing now, would you support or think it would be appropriate in any way to water down the standards of care that are currently in place?
That is really beyond my level of expertise and my mandate within the role at Orange, so I don't think I'm in the position to answer that.
Well, let me ask you then, as a paramedic or a former paramedic,
Yep.
do you think that it would be appropriate for an organization, or would you as a paramedic want to be placed into a situation where you're asked to go out on a call knowing that the standards of care prescribed by your profession are being compromised?
I think I would look upon my leadership to determine what best works for the organization. And my job as a paramedic was to do what I could for those patients in whatever circumstance I was in. So I think that's probably the best thing that I would do, is I would do what I could for my patient at the time.
Can I rephrase this? Standards of care are set by a profession. Do you believe that a paramedic, a nurse, a doctor has a first responsibility to the profession and the professional standards, or to the employer who may decide that the standard of care set out is too high, isn't necessary? Who rules here? Is it the employer or is it the profession, in your opinion?
For me, the driving force is always the patient and doing what's best for the patient. So I think morally, a paramedic is driven by providing the best care they can to the patient and providing a really high patient care experience for those people that they care for.
And those standards are set by the profession?
Yes.
Okay. Thank you.
We'll move on to the NDP. Ms. Gillinas?
I only have some odds and sod question. They have no relationship to one another. The first one is, you are to report to the leadership, that is the board of director or the executive director, I'm not too sure, 6 times a year. Have you done a report so far?
So just to clarify, I report to the executive 6 times a year.
Okay.
And then a report is provided to the board of directors 6 times a year. And yes, I have.
And who prepare the one that goes to the board?
I prepare it.
You prepare both?
Yes, I do.
Okay, would you mind sharing those with us?
I can't see any reason why not.
Okay, and how many have you prepared since you've been there?
Since I've been there, it's been 3.
3? Okay,
3.
very good.
Before we determined how often this was going to take place, it was my recommendation to set up some sort of process so that it happened on a regular basis. And for right now, what we agreed upon was 6 times per year, and then any time I feel it's necessary that they get pulled together, and I provide those reports.
Okay. When you were first hired, or since you've been hired, have you heard anything about a whistleblower policy?
Yes, I have.
And how did you find out?
I believe it was emails through our communications center about a whistleblower policy and how we can access it and what it meant.
And do you remember what it said?
This is where things get cloudy for me, probably because I wasn't really concerned about it at the time, but I know that it's very visible on our website if I want further details about how to report. I know it's from a third party, and I know the process of accessing that policy if I want to talk to anybody.
Okay. Have you referred anybody to the whistleblower policy?
I haven't felt the need to provide that information, but if it came about, then I certainly would.
All I have to say is thank God. And on your website, coming back to your job, forget
Yes.
the whistleblower, there are a bunch of questions that are not related.
Okay.
If a patient goes to your website, how easy is it to find out how to put in a complaint with you?
This is where I think a huge improvement has been made since I've started. So if they go to our website, there's multiple ways to make complaints or requests or inquiries. Through our main webpage, there's a contact us information, and then they can click on that. Or they can click on a patients tab, which opens up my profile and what I do. And then from there, they can either call me by direct line, there is a direct email address, or they can fill out a form, whichever one they prefer.
Okay. And the concern that comes from the general public, which seems to be a big percentage of the concern, you said 12% patient, 7 family, 50% stakeholder, and the rest of them being, that's still a fair amount.
Yes.
Who are they, and what are they talking about?
Some of them may be making noise complaints about our vehicles. Some of them may be inquiries about our academy. How do I become a paramedic? What do I need to do? Who do I need to talk to? Some may just have general questions about our system. I'm an organ recipient. When things happen, what services do you provide? General questioning, mostly. Those are probably the bulk of the ones that I can think about right now.
Okay. No more questions.
Very well. Thank you very much. We'll move to the government. Ms. Jazik?
Yes, just following up, you've now got your electronic database and it's being sent to various people. In terms of the Ministry of Health, what's the reporting relationship? Do you have a direct reporting relationship?
When the complaint comes through on the system, our investigations department determines if it meets criteria for the ministry to be notified immediately. I've presented in front of the ministry once about my role and how we're doing there, and I attended one investigations meeting to meet all of them and kind of start to learn about what that process is. And then I've had a couple of conversations about a few complaints and if they're running their own vet investigation, what's happening with that, what has the communication been with the family, and how will we work in conjunction with each other to communicate with the family.
So this is where they've called you?
Or I call them.
Or, so you feel totally free to have that kind of interaction?
Yes.
Yeah, okay. Now, who is on this investigations unit? You have said it goes there?
There's a director, a manager, and a coordinator for investigations. So they do all the fact-finding and develop the report that then goes to the leaders and myself for review to find out what happened in the process of the complaint.
So that always comes back to you, and you can decide whether you're satisfied with the investigation?
Well, it's not my determination. The family needs to decide.
Okay, yes.
If they're happy with that,
You're
but-
their advocate, so you convey to them, this is what we found, and then they respond to you.
Yes, and I'm not the only one involved. So if families have questions about the process, I certainly can't answer to operational decisions of what happened. So the most appropriate, or what we call the most responsible person, is almost always on the telephone call as well to explain those particular operational decisions to the family or to the patient, and then I facilitate that process.
Right, thanks. Now, this quality improvement plan, are you familiar with this document?
Somewhat.
So, there is
Some homework to do.
There is something here in Appendix A that I find interesting. Every year, it is the expectation of the ministry that a quality improvement plan is produced. So this is the one that was produced for 2012-2013. And what it says is the annual quality improvement plan must be developed having regard to at least the following: the results of the surveys, data relating to the patient relations process. So in terms of these surveys, does something go out to every single patient served by Orange?
The process for sending out patient surveys is that they can only get the survey once, and it has to be within 6 months of transport. So I think we've been averaging between 800 and 1,000 patients every 3 months.
Okay.
And that goes out to them to provide feedback to us. And then all our results are posted on our website as well.
What sort of response rate do you get to that survey?
In general, like if you wrapped them all up, but I'm only taking a guess, but it was very high.
It was high.
Yes.
Yeah. And did you develop that survey, or were you involved at all?
The survey happened before my time, but I'm now leading the metrics of that survey and review the questions from time to time to see if there's a different question we need to ask, or if it needs to be rephrased, or if the question is valid, if it's been
Right.
validated. So it does evolve and it does change depending on what feedback we're looking for.
And presumably what you're hearing out there, if there's some new aspect that hits you, you might want to zero in on a particular aspect, I presume.
I can give you an example of that. So we saw that the patients responding were starting to get a little concerned about blankets that they were receiving in the winter. So then from there, I can work with the operations managers to say, are we providing enough blankets? If we're not, this needs to be reminded. We can put that in a newsletter. I could put that out in one of our weekly updates to remind the paramedics about meeting basic care needs and keeping our patients warm and what that means.
So do you know if you're going to have input to the quality improvement plan, the 2013-2014, or?
I think that's a great question, and I will definitely ask my vice president to be on that.
Okay, thank you. I think that's, any other questions?
Any other questions from the government?
What kind of staff do you have to handle all these complaints? Is it a big
I am it.
organization?
She's it.
I am it, but I work with various other departments that help me. So I don't have to run the investigation on my own.
Somebody else that does that.
Somebody else does that. And depending on who the most responsible person is, I work with them. So even though I'm the only patient advocate, I have a good amount of team members to help me throughout that process.
Thank you.
Very well, thank you. We'll move back to Mr. Klees. Go ahead.
Yes, thank you. You were in your job on November 23rd, 2012, I'm assuming.
Yes?
Do you recall the incident in the region of Waterloo There was a situation where Orange responded to an incident, and we had that incident of a single paramedic responding. And unfortunately, I'm going to read the quote from John Perno, who is the manager of the Waterloo EMS, who said, and I quote, "The air ambulance knew it couldn't transport the woman found trapped in her rolled over car before it left London. He was concerned by what happened." He goes on to say, and I quote, "Orange had some significant staffing woes. Sometimes they launch aircraft with one paramedic on board without enough to care for a critical patient like that," he said. "Having a speedy response with a lower level of care, that's a problem." Do you recall getting a call from the EMS in Waterloo regarding that particular incident?
I have no recollection of that call or any involvement in that. It's not ringing a bell to me, no.
Well, what's interesting about that is that this made the news. I think it was on television, it was in print media, it was very widely reported, and you as the patient advocate or the individual, the point person, wouldn't have known about this?
With the information you've provided me, it's not coming to me with what you've provided. So without looking at my records, without looking at my data, I don't know if I'm aware of this, Colin.
Okay, I think, I would think that what you may want to do is get a newspaper clipping service or something for your department, because we certainly knew about it, and I would think you would want to. But here's a quote from Mr. Farr, who was asked about this. He said, "From time to time we find ourselves in a situation where a staff member either books off sick or they're not feeling well and they have to go, so we're left short. In those cases, we believe it's in the best interest of our patients across Ontario to launch a helicopter to assist the land EMS crews." End of quote. This goes back to the issue that I was following up with you just a bit earlier, and that is standard of care. The EMS manager was not impressed. The EMS manager is saying, look, it's not good enough for you to send a single paramedic. That doesn't help us. What I'm concerned about, and the reason that we continue these hearings, is that I would think, obviously, you're providing value added to this organization. We want to make improvements. The job of Mr. Farr, in my opinion, is not to make excuses about people being off sick. The job is to staff up so that we know that 24/7 we do have the appropriate number of people on staff, so that when the calls come in, you'll be out of business. You shouldn't have a job, with all due respect. You should be on the front line providing the paramedic service. We shouldn't have to have a full-time job to take complaints about an emergency helicopter service in the province of Ontario. And this has got nothing to do with you. And I'm hopeful, and I think you're already providing some help in getting this organization leveled out. But it concerns me, as a member of this committee, to continue to hear, even today, from Mr. Farr, that that's the way it is. People get sick. We know they do. And because we know they get sick, and because we know that there are going to be incidents when people aren't going to go show up for a job, surely we have the ability to staff up, and surely we have the ability to make the necessary arrangements so that when people in Ontario who need air ambulance and call are not going to be disappointed. So I wish you well in your job, but I hope soon enough you'll be out of a job.
Okay.
Okay.
Thank you, and the auditor had a question or?
Just a quick follow-up question, something Mr. McNeely was saying. You mentioned, we were talking about staffing, and you mentioned that you've got a lot of complaints and no staff, and often when you get a complaint, you would refer it to one of the areas in Orange to investigate and report back to you. It's a little bit like sometimes the situation we auditors get in, we go out and people report back to us. Often they tell us what they think we'd like to hear. Do you see any risk that when you would say to go to the Thunder Bay base and you'd say, well, we got this complaint, could you report back to me, Thunder Bay, on what happened? Do you see any risk that what they report back to you might be slanted in the sense to, how could I put this, to protect what they did and may not be totally accurate? Do you see any risk there, and how do you handle a situation like that? I'm just curious because we face that as auditors all the time.
Okay. I think the processes are set in place in order to get the appropriate and factual information. One of those is through an incident report, and that is governed through the Ministry of Health. So there are certain criteria that the paramedics have to provide within that. We can look at medical records, which are factual. The investigative report is also only factual, so if that's listening to audio tapes, looking at other transport records, a combination of all of those facts are all brought together for the report.
So I think what I understand, you do something similar to us, as well as getting a report back from them, you would actually go back often to the original documentation just to see what did the flight log say, what was the audio. So you would actually go back to follow up on that just to sort of get some corroborating evidence.
Yeah.
Okay, that's...
Like if I read the report, but then I look at the family complaint, and there's still an outstanding question in there,
Yeah.
I can ask for additional information, particularly through the investigations department, to say, can you ask the medics this particular question, just to make sure that that information is consistent.
Okay, that's great. Thank you.
Thank you. We'll move to the NDP, Ms. Jelinek.
Just a very quick question. I understand that there's only one of you.
Yes.
And I serve a large district in Northern Ontario. Close to 30% of the population I serve are French-speaking. I know that your website is in English only, and
Yes.
the complaint form is in English only.
Yes.
How do you handle French callers?
I haven't had that yet, but I know that there has been discussions with the executive team about making changes to our website in French. I don't know all the details to that, but I think that's a valid question, that's something that we could potentially make improvements with, depending on what we need to comply with. But I haven't dealt with that yet. I do know that we're looking into trying to find a delegate who can provide translation services so that I could still be involved and still advocate for the patient or find out what happened. That hasn't happened yet. It's something that I know that there's been some initial discussion on what we can do to improve that.
So if you go back to work this afternoon and a French caller calls, what happens?
I would probably connect with my VP and ask for some direction on what do we do to communicate with this individual. My understanding is that we have a translation service, but I would need to identify where to reach those services and how we could utilize those.
Okay.
And that's something I will do when I go back.
Okay,
Thanks.
thank you.
Thank you. Any further questions from the government? Very well. I believe we're done. Thank you very much for coming in this afternoon.
Thank you very much.
Appreciate it. And I guess we're
Next Wednesday.
adjourned till next Wednesday at 8:25 a.m.